So it is June 17th at about 1 p.m., 1:05 p.m.-ish. And we're going to start with today's review session. I've been monitoring you guys in the crash course. How do you like the crash course so far compared to the regular course? Is it frying you? Yeah, it's designed that way. I know that it's kind of just go, 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 brain fry. I had some issues with some of the questions last night that made me mad, so I'm just gonna keep those to myself. I still don't agree with the dorsiflexion stop, but whatever, or plantar flexion stop.
I was gonna say the same thing.
Yeah, and so here's the deal: is I've talked to about 5 different orthotists, and like 2 of them agree with it and 3 of them disagree with it. So it's just amusing that it seems to be this argument now. I would hasten to bet you're not going to get questioned about stops. The only time you really get a question about actually dynamic orthotic issues is if your patient's having problems with toe drag, that you want to add a dorsiflexion assist. So that's the main thing with orthotics that you'll get. So I doubt you're going to have questions about stops. Yeah, Jason.
What about that foot drop or foot slap question? I don't know. That one's too, I mean, all the answers are basically foot slap is where my head was. So I was really confused by it and was like, is that, are they going to get that detailed on the test?
No. Yeah, the answers were definitely a little too vague. There was too similar and then too vague on top of it, right? So if you get a question on the board that's going to talk about like either tibial nerve palsy or, patient with, already existing foot drag or tibialis anterior weakness, a lot of your answers are, one of the answers is going to end up being some form of foot slap. So whether it's, foot drop, right? Foot drop is just where the foot's kind of dangling. And foot slap is literally the initial contact problem. Right, that's where the person kind of kicks the foot up in order to get the foot to go up, and then it slaps down. So you use kind of an exaggerated knee extension to get the foot to kind of dorsiflex, if that makes sense. You kind of kick the foot up into the air. And then when that heel strikes, the foot slaps down. That's different than foot drag is just where they're dragging that foot across the ground. Does that make sense? So it's a compensatory technique. So they're likely to ask you more along the lines of, which of the following you might encounter. So if it's a dorsiflexion problem, it's going to be either foot slap or foot drag is one of your answers, right? And so foot slap would occur at initial contact, and then foot drag would occur during what? Part of gait.
The loading.
Swing.
Not quite. Swing. There we go. Yeah, swing. Right. So one of those is a loading response, right? And one of those is a swing. So those are what they're going to be. So if it talks about patient has tibial nerve palsy, anterior tib weakness, and during swing phase, what are you likely to see? That would be foot drag or toe drag, right? And then it'll say patient has blah, 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 blah. During initial contact, what do you like to see? And it will be foot slap. I mean, I've seen it enough. Now they're trying to get you guys there. I think sometimes in his best interest, Dr. Crane goes a little overzealous on his orthotics because he sees a lot of patients with foot drop and stuff like that. And, when you see elephants all day, all you think of is elephants. That makes sense. So I think he went a little overzealous on that question. And also it could be worded just a little smoother. But that's beside the point. There's one other one that was really worded poorly, I thought. I think it was the one about RA, if I remember correctly. Because I think it mentioned just a single hand issue, if I remember correctly. And really RA is what? Typically.
Bilateral. Yeah,
bilaterally. And that's how you'll know, like in a question on the boards, it'll mention basically, bilateral nodules and ulnar drift. That's when your brain automatically goes to RA. Right? Versus pain in the hands, comes and goes, is worse in the morning. That would be what? Oh, wait, I see your mouth in it. Yep. Yeah, OA. Now, can we treat both of those with paraffin? As long as the OA is not in what?
Flare up.
Yeah, acute flare. Yep, good, Anthony. Yeah. So for the most part, we can treat both of those with paraffin as long as we're not in an acute flare. All right, so I went through kind of a shotgun approach. The only thing I don't have on the slides is psychological disorders, but we'll hit those kind of at the end here. And I did not put a ton of information on the slides. I just kind of put the diseases so we can kind of go through them as we go through and talk through them rather than me give you 50,000 information on the slides. So let's talk about musculoskeletal. We'll go musculoskeletal, neuro, and then cardio, and just go through the most common pathologies you're going to encounter on the boards. So musculoskeletal, probably one of the bigger questions you're going to get on musculoskeletal type pathologies is adhesive capsulitis, otherwise known as
Frozen shoulder.
frozen shoulder. Yes, but
Shoulder.
remember, Dr. Vreskin says the shoulder doesn't get cold, so it can't be frozen. Who is more likely to get frozen shoulder, men more than women, men or women?
I believe men.
Men.
Oh,
Yes, men. Men are more common, and the idea is because we have more manly jobs, so we're more likely to get it, right? But I think if we look at over time, I bet we're going to see it starting to flatten out, kind of, that everyone's kind of getting it. With frozen shoulder or adhesive capsulitis, it can take 1 to 2 years to resolve, or it may never resolve, right? We've got a person on campus right now, one of the staff that has had frozen shoulder now for about 2 years. And there's no direct imaging that shows, well, this is what's causing it is the problem either. It's not like we can go, oh, well, it's this. He woke up one morning, his shoulder won't go past 60 degrees and he can't get it resolved. So sometimes those things just happen. So what do we do to treat it? Range of motion, right? Which is going to include both passive range of motion, active assist range of motion, and stretching. And also the main thing with adhesive capsulitis on your boards is going to be, because it is the joint capsule that is the problem, we are going to do joint mobilizations, right? What's going to determine what direction we do our joint mobs?
Whether it's convex or concave.
Okay, good.
The limitations in range of motion,
Yeah, limitations or range of motion. What's our most common limitations in the shoulder?
lateral rotation, flexion.
abduction.
Yep, there you go.
Yeah, flexion.
There we go. Good, right? Which is the worst usually, though?
Lateral rotation.
Yes, external rotation is the worst. Yeah.
Correct.
Yeah, it's whichever you want to call it, because I just remembered it's ER because that's what I grew up with, but lateral rotation sounds more efficient. So yes, lateral rotation is usually the worst overall. So that's going to be the most restricted. And remember, if they're just lateral rotation, I still worry about it being frozen shoulder in the clinic. Even if they've got no flexion or abduction issues, I still worry a little bit in the back of my head if it is a capsule problem, right? But if it's just flexion, not a capsule problem. If it's just abduction, not a capsule problem, right? But if it's a combination of those, definitely capsular. And then we just look at whatever the problem is and we mobilize for that problem. And if they have problems for all three motions, we're probably going to mobilize for all three motions. That's kind of the idea. So we just kind of look at whatever motion's our issue and mobilize for that motion. And for the most part, again, in most joint mobilization situations, it's just the opposite direction, right? For most, safely, it's mostly looking at which way it's going and then kind of go in the opposite direction it's going in order to mobilize it. The wrist is a really good one for that. If it's ulnar, it's radial glide. If it's radial, it's ulnar glides. So the wrist is kind of our teacher of that. Modalities are going to be based upon acuity, right? So if it's acute, we're going to do cold and maybe some E-stim. If it's heat, or if it's chronic, we might do some heat. And then, is surgery an indication for adhesive capsulitis? Not
No.
usually. Not usually, yeah. And the main reason is because the doctor can't figure out what the problem is anyway. Now, if it's a rotator cuff repair, yeah, it's easy to go in and do surgery, right? But if it's just not moving, there's not much they can do. So that's adhesive capsulitis. Congenital hip dysplasia. What demographic is likely to have this?
Infants,
Children?
Children, good, young children and infants, specifically what gender?
I would say boys.
Who has the most problems with their hips, ladies? Yeah, you guys do. That's a hint, right? Yeah, I've seen it, and specifically most of it says it's usually young girls. And I wouldn't doubt if we went back to it, it probably has to do something with Q angle. Like even at that age, it probably, if we go back to somewhere back there, I'm probably sure it has something to do with that weird pull. I can't, that's not a board thing, mind you. That's just me kind of postulating out there. Usually it's a mispositioning in utero that starts it. And then it's a malformation of what part of the hip, usually?
acetabulum,
Acetabulum combined with,
femoral head,
there we go. Yep, there we go. Yeah, so the acetabulum doesn't grow right, so then the femoral head usually is shrinked. So it's smaller, which means that it moves really easily in and out of it, right? And literally, if you ever treat a kid with congenital hip dysplasia, it's gonna be honest, it's kind of gross because their hip will literally dislocate as you're treating them constantly. And what do you do if you're a pediatric therapist or pediatric PTA? Pop it right back in. Now, technically, that would be a grade 5 mobilization, and we don't do that. And I do not admit to ever doing a grade 5 mobilization on those patients. I will deny that to my dying day. But in general, that's what we're doing. Right? Some teratogens are out there. Yep, go ahead. Sorry.
Sorry, so you're kind of talking about like the slipped capital femoral epiphysis?
Yes. Yep.
Okay.
Yeah.
Okay.
Yeah. So capital femoral epiphysis just means top of the femur slips.
Right. Okay.
That's all it really. It's a fancy way of saying that the femoral head slips out.
Right. Okay.
We're going to talk about this, but we're also going to talk about a total hip replacement later. What is the structure on the top of the femoral head that provides the femoral head with blood flow? From anatomy.
The growth plate? No.
No.
No, never mind.
It's a little hole that sits in the top of the femoral head.
Foveum, am I getting it close?
Yes, you are.
I don't
Yep.
remember the rest of it. What's the rest?
Fovea capitis.
Capitis. I was thinking, yeah, all right.
Yep. So just remember, it's basically fovea, meaning functional hole in the top of the head, capitis. Right? Fovea capitis. So if they have poorly designed fovea capitis, maybe the femoral head doesn't get enough blood flow, so it doesn't grow. That's possible. Some teratogens can also cause congenital hip dysplasia, and then also the environment in general, especially if you look at it, we talk low socioeconomic status is more likely to have this and stuff like that. So lack of health care, all that fun stuff. So treatment for this for us is going to be based upon symptoms, obviously gait training, sitting, standing, all that fun stuff, right? But most of the times, eventually this child is going to have an open reduction internal fixation of the hip. And then they're going to be put in what's called a Pavlik harness. And the reason I put this on there is because your board often will ask, your patient is placed in a Pavlik harness. What is the likely condition that resulted from this? And that's congenital hip dysplasia. And the Pavlik harness is really just brutal for the kids because it basically takes the hips and it positions them in external rotation, a little bit of flexion, and abduction. So they're kind of out like this. And the idea is it puts the femoral head into that socket the greatest. And so they're in that and they can't come out of that harness until the doc says so. And if any of you have ever had a child or have dealt with children, they really don't like that. They don't like being restricted in movements. So they're not going to be very happy at all being in that harness. But usually that's after the ORIF. So they're going to fixate the hip. Why might they wait until the child's a little bit older before they do any surgery?
so that the kid understands that they can't move around.
That's part of it. Good.
They're fully developed.
A little bit more development. Yeah, there's a bigger one, right? Yeah, because, you know, if I do an upward reduction internal fixation on somebody that's like a month old, I'm in 3 months, I'm going to be doing it again because baby grows, right? Do you think this might affect the person's height? Yeah, it can. So that's not part of the board question, but it could definitely affect the height. Looks like we're going on to another congenital torticollis, right? Now we have congenital, and then we also have functional torticollis, which I don't have on here at all, right? But congenital is typically child, and it's usually because, honestly, it's mostly small mommies that cause congenital torticollis, because you get, you know, baby who may be 8, 9 pounds in a mom who is 90 pounds. There's not much room for baby to grow, right? So head gets kind of twisted up. They may end up with congenital hip dysplasia too, which would suck that they get both of them. But if the head gets kind of twisted and they end up with SCM issues, right? Could be birth trauma too. It could be the surgeon pulls on the neck as they're coming out. That could cause hip or torticollis as well. So if we have a patient that has torticollis, excuse me, it's not going to matter whether it's congenital or whether it's structural. We're going to look at the direction that they're turned and leaned, right? Then determine which SCM is the problem and then just reverse it. So if I have a flexion to the right and rotation to the left, which way am I going to stretch?
Flexion to the left and rotation to the right.
Yeah, good. You're just going to reverse the motions, right?
And
so now you're lucky if your boards give you that motion. Most of the time they're going to say your patient has left-sided SCM torticollis. So if I have left-sided torticollis, you have to go, okay, it's over here. I'm like this. I go the opposite. Does that make sense?
That's what I was just about to ask. It's when they say left-sided, it's
That's the short side.
And yeah, okay.
Yep. What does SCM stand for? Sternocleidomastoid. Yeah. Yep. That's okay. That's better to ask them to sit on your boards and go, what the hell is SCM? Right. So sternocleidomastoid shortening, right? That's the muscle that's tight here. Sometimes they may have to do surgery, but that's not really in our purview if the patient's gone fibrotic, right? So if maybe mom or doctor doesn't think that their torticollis is that bad and holds off on sending them a PT, the patient may eventually develop a fibrosis in that SCM, and they may have to go in and lengthen it, which would suck because babies don't do very well with surgery. I'm just warning you in advance. They don't like it very much. So for us, stretching, right? Maybe a little bit of heat. Does anyone know what position we teach mom to carry the baby in? What it's called? There's a specific position. You're gonna laugh at the name. It's football carry position, right? So let me get my stuffed animal over here to demonstrate it, right? So I got my space dog here. Isn't he cute? It's great. So if my space dog has a head turned like this, right? What I want to do is lay him on that side, cradle my arm under that, and rotate him like that. And I cradle him here. Because what am I doing? I'm just doing the SCM stretch by cradling child, right? And so then, oh, baby, baby. And baby doesn't know it's being stretched because what does baby feel?
The mom carrying them.
The parent, yeah, right? Oh, I'm being carried. Right, I'm being taken. This is a little easier way to stretch them, especially if you're ever in a clinic and treat kids. This is obviously not a kid. But if you're ever in a clinic and you need to stretch that kid's SCM, so look at the way the head's turned, right? Start the stretch and put it in that position. Cradle your arm across the head. Put them in this kind of what's football carry position, right? It's a great stretch while coming from the baby. The other thing is now you can take the baby and walk the baby around the clinic. Right? And we all know that babies like stimulation. So now you're sitting here, and as you're moving, you're kind of bringing that arm up a little bit more and a little bit more. And baby doesn't realize they're getting a stretch. it works out really well, right? So they call that the football carry stretch. I don't know if your boards will have anything on that, but that's a great trick when working with the baby, right? Where you can kind of trick the baby into thinking, oh, well, I've got warmth. Now, watch out, because that means you're going to get baby drool on your arm too. So hopefully you're okay with that, right? I guarantee you put a baby in this position, you're going to get drool on your arm. That's just the way it is, right? The other thing you can do, and I've done this trick in the clinic as well, is when I'm holding him like this, have mom feed them. Because babies are food driven. And if you associate this position with feeding, they're less likely to resist when mom needs to feed them later. Now, obviously, yes, so I have the short side, right? So here's the position, right? Oh, let me get his head. Right, I have the short side is over here. That's my right side, right? So I have my right side against the arm, yes. Right? Now, if mom needs to breastfeed, that doesn't work for this position, just to let you know. But you can modify it for mom, right? Now I can modify it and move the head in and get a similar position if need be for mom, obviously. I'm not going to breastfeed the child. That's not happening. All right. But those are different modifications when in the clinic. Again, that's more clinically relevant than it is boards relevant, but it's nice to know that you kind of have some tricks. And then positioning. What do we want to recommend? The big thing for any type of congenital disorder with a kid, what position do we recommend for mommies to put them in? Dr. Reskin hit this pretty heavy. What do we want the babies to be in as much as possible? Tummy time, right? We don't want them laying back like this where their head can get tighter, right? We want them on their tummy where they kind of have to lift that head and use the muscles of the head. So tummy time is important.
Mr. McKeever, just to get this right, if they have a tight left side, you're gonna stretch them right. I know you have to stretch the right side. No, wait.
No, so if I've got left torticollis, right? So that's the side it's named for. So my left SCM is tight, right? So that means my head is going to lean to the left and rotate to the right.
Okay.
I'm just going to reverse that. So I'm going to rotate to the left, lean to the right.
Okay.
Just remember that the rotation and the lean is always opposite each other.
Okay.
So, because there's going to be a question, it'll be like, left side bending, left rotation, right side bending, right rotation. Those are always out no matter what, because you don't rotate and turn to the same side. Does that make sense?
Yeah. Thank you.
So then you get down to 2 answers and you just have to do it on yourself. That's honestly the best way I can say with these questions is put yourself in the position of shortening and then just reverse it. Does that make sense for torticollis?
Yes, thank you.
Yeah. I have juvenile RA down here, but I'm just going to say all RA. Causes of it pretty much are autoimmune and idiopathic. We don't know necessarily the triggers. We do know that there is some congenital or some genetic link between RA and children, right? So if mom or dad have RA, there's a chance a child will. And that's actually true for almost all kind of RA style disorder or all autoimmune disorders, right? Main treatment for RA, right? Paraffin, NSAIDs, steroids are the main treatment doctors are going to do. For us, again, paraffin's big. And then what would help? Maybe move the fingers that Dr. Avreska might have taught you to help the tendons glide better in their sheets.
Those.
Yes, 6-pack.
That's what they're called. There you go, the 6-pack.
Right, the 6-pack is important. Yeah, 6-pack's really good kind of for people with RA because it's very gentle, right? They're not doing a ton of squeezing and stuff like that. And if we've got an ulnar drift going on, what side do we kind of want to probably work towards?
Radial?
Radial, yeah. Now, are we ever probably going to get them back? Probably not, right? Once that ulnar drift starts kicking in, it's our job mainly is to keep them from going too far into that ulnar drift. Because like I've seen people with ulnar drift hands like this, where they can't even get back to center. So if we can at least start getting a little bit back to center and keep them from developing worse, we can. That's the benefit. with RA and pretty much all the other autoimmune disorders, we want to work them, but we also have to monitor that we don't work them too hard, right? Because if we work them too hard, they could end up in a flare, which would make it a lot worse. So it's just kind of monitoring their signs and their symptoms as they're going through it. If they have a ton of pain with something, probably not a good idea to keep that going, right? What else could we provide them maybe in addition to exercises and kind of an idea of how to treat the condition that they could go home with that might keep their hands out of that ulnar drift?
Splint?
Splints, yeah. Splints or orthotics, yeah, definitely, right? And especially splints that might extend them out so they can keep that extension, because eventually they're going to flex and ulnar deviate. And so if we're in this position, right, I'll get you, my pretty, and your little dog too. You're not going to be doing much. So you need that kind of extension. And honestly, for most hand conditions, a lot of times they're going to be splinted, right? One of my favorite diseases of all time, just because I like the name, Osgood-Schlatters disease. I'm wondering to when this will become tibial tuberosity disease, because we don't want to call it Osgood-Schlatter. But Osgood-Schlatter, as soon as that pops up as a question, your brain goes to young and male, right? Just as soon as that pops up, young and male. And then if it's asking which is most likely to have it, go down and find the young male. Typically puberty range, because that's when things start growing. That came out wrong. Thanks, Jason. I appreciate it. I see you laugh. I saw you get that face when I said that. Right? So young and male, it's a condition of the tibial tuberosity. Do we know what causes 100%? Not usually, but a lot of times young athletes get it worse because they're really stressing that tibial tuberosity out, doing jumping, pushing, lifting, whatever it may be. This is definitely a reason for kids to probably not do squats. I saw at the gym a few weeks ago, I saw this guy, he had his like 9 or 10-year-old kid in there with him, boy, and he was having him do like 110 pounds on the squat rack. And they were doing butt to floor squats. And I'm just like, man, this poor kid's going to have torn up knees before he gets to puberty. Right? Just think of all the pressure on those growth plates doing that. That's not good. He's going to be short. Dad was short too. I think maybe dad did it when he was 9 or 10 too. I'm just kidding. But Osgood-Schlatters is an excess growth on the tibial tuberosity that's going to affect the pull of the patellar tendon, and that's going to cause pain. It's going to feel a lot like growing pains, but the difference between that and growing pains is growing pains come and go. Right? When you get growing pains, you guys remember back when you were kids, maybe, you get those growing pains in your muscles and your bones, and they just kind of ache for a while, and then they'd go away, or you take some Tylenol and it'd be good. With Osgood-Schlatters, a lot of times it's just consistent, annoying pain. The main treatment from our standpoint is icing. Right? So ice massage, right? So they may combine an Osgood-Schlatters question with ice massage, where they'll ask you, how long should you do ice massage for? Or how large should the cup of the ice massage be? Something like that. That would be a good combination of the questions here, and that would turn the Osgood-Schlatters disease question into a non-systems question. So you're thinking Osgood-Schlatters going down looking for young male, and they're really just asking about ice massage. Right? So be able to identify where they're going with it a little bit.
And it would be a treatment of like 10 to 15 minutes.
Ice massage is the one that's odd. 5 to 10. Right? Ice massage is the weird modality. Most of the other ones are 15 to 20. Gym associates should be, yes, absolutely. I agree with you, Alex. He said the gym associates should be trained on. Absolutely. But I can only feel for them for so much, Alex, because most of them get like a week's training. Congratulations, you're a gym guy. Right? It's not like they get a ton of training. That's the sad part. Hey, wait a minute. I didn't get a ton of training. No, just kidding. I don't know if you guys realize this or not, but I literally, when I was hired for PMA, I was hired on a Friday and I started teaching on a Monday. And I started teaching Neuro that day. That was a great part. But anyway, icing is there. We could also maybe do ultrasound. What ultrasound would we do?
I'm just guessing chronic.
Okay, it would maybe be chronic, but pulsed is the idea there, Anthony, right? Yeah. Pulsed is the main idea because it would be a healing problem. We're not trying to heat it up, right? So we probably do pulsed. And again, the rest of it would depend upon your patient, right? But good idea for pulse, most of it starts at about 0.5 watts per centimeter squared. That's about it for Osgood Schlatter's. Wow, did I butcher the spelling on this one? That's supposed to be osteogenesis imperfecta, not osteogenesi. We're summoning genies with genesi, but osteogenesis imperfecta, otherwise known as brittle bone disease. There are 5 different types of it, and you have to know all. No, you don't have to know all 5 different types. I was just joking. And with the 5 different types, the only thing you really have to know is it's in level of severity. Does that make sense? So the worse you are, and I don't remember off the top of my head, I think it's the higher you go, the worse it gets, but don't quote me on that. You guys don't have to know that. But it means brittle bone disease. That means the bones have a problem with absorbing what mineral?
Calcium?
Calcium, yeah. That's also going to mean that you have an excess of what mineral in the blood? Calcium, right? Because if it's not getting absorbed, it's got to be somewhere, right? So you usually have hypercalcemia in the blood. So with osteogenesis imperfecta, for us, from our standpoint, we may do splinting, but the idea is injury prevention here, especially to prevent them from doing what?
Breaking their bones?
Yeah, breaking their bones. That'd be bad. And it is nothing for these patients that have osteogenesis imperfecta to have broken their bones hundreds of times through their lifetime, which is kind of scary when you think about it. That's a lot of fractured bones, right? So for us, injury prevention, energy conservation, safety, all those fun stuff is our main goal here. And weight bearing, because the more they weight bear, the more likely they are to absorb calcium. So be sure that they're getting up and getting weight bearing, especially through those long bones. So that's it for osteogenesis imperfecta that I can't spell there. All right, so if I said that Osgood Schlatter is young males, then if it's a young female question, it's PFPS, patellar femoral pain syndrome. And it's usually due to the Q angle, especially when they're starting to go through puberty, because that's when your body starts changing, ladies, and you start getting ready for bearing children. And think about it, in the old days, by the time you were like 12 or 13, you were already starting to bear children. Wouldn't that be fun? No? Like, I was reading about something, what was I reading about? Oh, the Monarchs of Sweden, and it was something about, I want to say it was Gustavus Adolphus. His mom was 13 years old when he was born. And to me, that's just crazy, right? Definitely a different time than it is now, because that person would have a label on him if that was today's day and age. I'm not, please don't think I am promoting that either. I'm just saying that it's a totally different age than it is now. Yeah, we die at 30, exactly. So you gotta kind of, I guess, get it on while you can. I don't know. I'm talking about childbirth. What are you talking about? I see you turning red there. But yeah, so PFPS is due to, the women, especially the Q angle. For us, it's going to be symptomatic. We may do some cold therapy with it, some cryotherapy to relieve pain, right? But the main idea is patellar tracking, helping that patella track in the right kind of groove. And with that, usually we're going to talk about taping, right? And also we're going to make sure that the the lady doesn't bring her knee in front of her foot, right? When we're doing squats or bending down, anything like that, right? So no knee ahead of the toes. That can really increase PFPS pain. Both with Osgood-Schlatter's and with PFPS, what athletic activity is likely to bring it on and make it worse?
Soccer?
Okay, soccer, which involves running.
Running.
Yeah, running, right? So just running in general, whether it's soccer, basketball, football, whatever it is, that's going to be the one thing that brings the PFPS and the Osgood-Schlatter's disease kind of up. And that's usually when the patient's going to talk about it. You know, you'll get a young female in, they'll be like, every time I run, I get pain below my knee, right? Or if you get men, they're like, or boys will be like, it's right below the knee. Well, same similar area, just different diagnoses, right? The fun one, Talipes equinovarus. What if you saw that on the boards? How many of you guys would freak out? Your patient suffers Talipes. Yes, okay. Anthony beat me to it. It's clubfoot, right? But if they put down Talipes equinovarus, if you're not paying attention, you may freak out because you're like, what the heck is this? Right? Just remember, Talipes equinovarus equals clubfoot, right? It is idiopathic, meaning it does happen randomly, but there is a familial link to it. So if you've got somebody that's had clubfoot, you may get it. There is a heavy link to spina bifida. And I'll say I've seen it a lot in spina bifida. But that kind of makes sense to me if you think about it, because spina bifida is a problem with the development of the spinal cord. And wouldn't your feet and legs be the last things to develop? Yeah, right. So it would make sense. So clubfoot is where the foot kind of clubs in and basically is heavily inverted and a little bit usually plantar flexed, or it could be dorsiflexed depending on the condition. But that internal rotation and inversion is the big kind of sign of it. They can't plant down flat. How do doctors mainly fix it? What's the medical management for it? Does anyone know? What do they do to fix the foot?
Well, I was gonna say splinting, but that's already listed.
Yep, so we're going to splint afterwards. We may cut tendons and then break the foot. They're going to go in and break the bones up. And then they're going to splint it in the position the foot should heal in. Does it always work? Nope. Right? And then the idea of serial casting, this is where you use Lucky Charms to help you in treating the patient. Get it? Serial casting. I'm funny. So serial casting is where we're slowly moving the foot out of inversion by casting it over a long period of time. You can also use that for people that have like shortened gastrocs, or actually any muscle you could do serial casting with. I mean, from our standpoint, a lot of what we're going to be doing is getting the foot back into natural position and then training the patient on gait. If their foot is totally, you know, messed up, they may never have normal gait. I know that I had one kid, and the kid would be, what would he be? Because I haven't treated them in 7 years. So I would make him, I want to say he would be 12 right now-ish. And they did all the stuff for the club foot, and it didn't work. And his foot was still inverted and kind of internally rotated. And we just taught him to walk on the outside of his foot, because that was about the only thing we could do. Now, he walked with assistive devices, obviously. But at the point that, you know, splinting and fracturing the foot and doing all the surgeries doesn't help, there's not much you can do other than compensate for what the issue is. Later on in life, maybe when he's finally an adult, they may just amputate the foot, right? Because would it be better for him to amputate the foot and get a prosthetic and have kind of normalized gait than walk around on that side of the foot all the time and then externally rotate the hip and all the other problems that go along with it? Maybe. So clubfoot, no joke. But again, if you see clubfoot, the main thing for your boards, think spina bifida. And make sure the question is about the club foot and not about spina bifida, because they like to do that a lot too. They'll talk about, talking about club foot. In reality, they're talking about what's the condition with spina bifida. So just pay attention. THA, total hip arthroplasties, typically caused by femoral head necrosis, again, from fovea capitis detachment, osteoarthritis, wear and tear, traumatic injuries can cause it as well, right? Just in general, for the total hip arthroplasty, they're not going to necessarily ask you what could cause it. The main idea of total hip arthroplasties is knowing the safety. My little meningocele. Yes, it is. You both are correct. Yep. It can be related to latex allergies. There's some link to it there, Joe. Sorry, I missed your question. I was already moving on. My brain is fast. But yes, it can be related to that. Yep, I'm going to cover that. I think I have that in neuro coming up, Anthony. If not, I'll make sure I cover it. So for total hip arthroplasties, the main thing you need to first of all figure out is what direction did they do the surgery, correct? I think she hit that pretty hard. I don't like the fact that they use posterior lateral and anterior lateral when they're talking about their questions. If you see posterior lateral, just automatically assume it's a posterior hip replacement, right? Don't let the lateral part of it confuse you. It is what it is, right? If it's a posterior hip replacement, it's a posterior hip replacement. So that means you need to know your precautions. Posterior, right? No flexion, no adduction, no internal rotation. So no bending way over, no crossing the legs, no turning your foot in. Anterior is no extension, abduction, and external rotation. We kind of covered that pretty heavily. And then anterolateral, or the newer approach, is dependent upon the physician, but a lot of times they'll give them anterior precautions for a time being. And then with the weight-bearing status, which surgery is more weight-bearing? The cemented or non-cemented?
Cemented.
Yeah, right? Now, again, what if you have a non-cemented hip replacement and the doctor says they're full weight-bearing? Great, we go with the doctor's requirements, right? So Alex asked, are we going to have to know? Did I put that in there? I'm sorry. Yeah, no extension, no external rotation, right? Or abduction as well, most of it. I'm sorry.
For the posterior approach, I didn't know that it was also no medial rotation.
Okay. Well, now you know.
But that's correct?
That is correct. Yeah, no turning the foot in.
Because there was a question in Scoliosis exam that got me confused, but okay, no worries.
Well, if you can find the question, I'll work with you on it.
Okay.
I'm not sure which one it would be. So Alex asked, we're going to need to know how long each stage of recovery is and what precautions for each stage. Most of it for that standpoint is going to be fairly logical, Alex, right? The main thing you're going to get there is what are you going to do in each of those stages? Yeah, 666 rule is great. Yeah, like go Slipknot. I mean, just kidding, right? So the main idea for when you're talking about the stages of surgical repair are in the acute phase, you have acute, subacute, and chronic, right? And chronic doesn't necessarily mean it's a chronic problem. That just means we've moved past or long-term repair or return to function, whatever term you want to use for that long-term period. So acute, a lot of passive range of motion, a lot of grade 1 and grade 2 MOBs, ice, that type of thing, right? Subacute, we can start getting into grade 2, 3 MOBs. We can start getting into some maybe heat later on in the period and a lot more active assist moving to active. And then once we get to that chronic or return to function phase, that's where we start getting into more heat and more active range of motion. And then we can start getting to those grade 3 and grade 4 MOBs. That doesn't change whether it's a surgery or whether it's just a patient that's got an injury. Those kind of things stay fairly consistent. Does that make sense? The treatments themselves all stay consistent just because of the phase of the injury. I'm trying to think back if I saw a lot of like specific questions on phases, and I don't think it's, again, it's usually just going to be phase of injury in general, Alex, thinking about it. Then we'll talk about total knees, right? Total knees, the main thing is wear and tear and osteoarthritis or previous trauma. If you've had trauma to the knee, you are likely going to eventually need a total knee replacement. I'm just warning you guys. Sorry, Riley, you're going to need total knee replacement eventually. Just kidding. If you've done anything where you've done a lot of like dance, gymnastics, sports, a lot of those patients end up needing a total knee replacement later in life. But even for total hip arthroplasty, I didn't add this, but we may be brought in for wound care, right? Dressing the wound, stuff like that. And that may be a question on your boards where they're talking about, you know, you see you have total knee replacement, they're talking about the weight bearing status and everything. And then you get down through it and it's actually talking about the wound, right? The wound is bright red with heat emanating from it. And we know that they've probably got an infection. And what do? Well, you contact the doctor, you let the PT know, right? Or maybe asking that your patient has heavy drainage from the wound. You know, what type of dressing might you pick? Those are also possible questions with both total knees and total hips. Where that, you know, you're going into it thinking this is just a standard total hip replacement question. In reality, they're really talking to you about the surgical site. So it's all about, and again, I'm going to preach back to this because I started talking, I forget who I was talking. I did a one-on-one this week and I don't remember who it was with. But I mentioned one of the things I tend to do when I'm reading a question is I read the end of the question first. And the reason I do that is the whole beginning of the question may be fluff. Or it may have what I need to solve that end of the question. So the question, you know, blah, 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 blah. What is the best dressing for this? Well, now I can go back in that question and read the question and figure out what my best dressing is. Right? I tend, and you don't have to do this. If it try it for a few of your questions, see if it works better for you. But it always has worked better for me is I read the end of my question because that's usually where the stem of the question is. And then I'll go back and read the full question. Because then the full question may give me my answer to my stem. Total knees are usually weight bearing as tolerated, but it's, again, based upon physician. And for both total knees and total hips, if you do a non-cemented approach, it's going to depend upon about the intermedullary material that's left, if they'll be weight bearing or not. So the older you are, the less weight bearing you're probably going to have, right? Because that stuff starts coming kind of dried out and powdery because you're getting old. And then for total knee replacements, the biggest thing you're going to see questions on, extension, 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 extension. Right? So keeping that total knee in extension. Don't put pillows under the knee, right? If your patient asks for a pillow, where do you put the pillow? Under the heel, yeah. Make them work for it. And then throw a 10-pound weight on their knee while you're at it. ISO first. Joe, always ISO first. Good question. So Joe asked for an acute injury. Should you start ISO or eccentric exercises first? I start ISO always. So that's where we're going to do our set exercises. And that's actually, that follows that acute, subacute, chronic thing as well. If we're going to do exercises, typically in that acute phase, it's isometric and no movement. And then depending upon the protocol, eccentric is one of the last added exercises usually, because it's the loading exercises, but it just depends upon the protocol. If you have a patient that is lagging in extension because they have had a total knee replacement, other than supine, what other position could you put them in that could help with knee extension?
Prone.
Prone with what?
Pillow.
Yeah, prone hanging. There we go, Diana, right? Prone with the leg hanging off the mat, right? So the knee kind of right at that edge of the mat, foot kind of off the mat to allow gravity to pull that foot down. And it does help with the screw home. Yes, it does. Absolutely. Right. It allows to pull that knee down into that lateral position or that medial position so it locks in place. So definitely prone hangs are another question you'll get. you may get a question that's talking about you're doing prone hangs with the patient. It's ordered by the doctor, but the patient is complaining about excess pressure over the knee surface. How do you solve that?
You move them a little bit more up.
You can move those. It depends upon where they're complaining about pain, right? Yeah.
Okay. So
pillow does work, absolutely. And then you could put, so a pressure relieving device typically would be the idea. It could be a pillow, it could be a towel roll, it could be whatever, right? Or you move the knee off the mat, right? So get the kneecap off the mat. Does that make sense? So that you're not putting pressure directly down on that kneecap. Now, that could also cause uncomfortability because maybe they're like, well, now my leg hurts. Too bad. Suck it up, buddy. Just kidding. But at some point, they have to understand what you're treating them for is not supposed to be comfortable. I'm just saying. That may have been a question, underscore builders. I don't know. I don't know all their questions, unfortunately. Yep. That's kind of why I cover it, because you never know what you're going to pop up there. All right, scoliosis. Scoliosis is a disorder of what?
Spine.
The spine. Good. Yes. And it can either be structural or functional. And you may have to be able to figure out which it is. If it's structural, can we fix it?
No.
No, yeah. If it's structural, that means it's bony. There's no way we can fix that. Yes, called physical therapy, not physical fun. Exactly. Yeah. Right. Or as I call it, I say PT stands for pain and torture. That's beside the point. So if it's a structural scoliotic curve, that means there's a bony block somewhere, right? Or bony problem. Other torture. Yeah, exactly. Or I'll say that it's, what did I say? It's optional torture. And they're like, I don't have to go to OT. Well, no, I mean, it's optional. You don't have to go to any therapy, but you're not going to get better. Functional is typically a problem with what?
Posture.
Posture, good, right? So the way I'm leaning here right now, I could end up with scoliotic curve, right? And so you have to understand where the curves are, what's causing it. And the questions on scoliosis are always going to mention their primaries or secondary curves, right? So if I got my spine here, I may have a primary curve and a secondary curve to correct it. Secondary curve is always corrective for the primary curve because we want to try to keep things straight over our base of support. I'm really losing my voice today. It's been a long week. So if I've got let's just talk functional scoliosis right now, the ones that we can correct definitely. If I've got and we're going to say this is left and this is right. And here's my primary curve. And I've got a secondary down here. We always worry about the secondary later because we could correct the primary curve and the secondary curve may auto resolve because it's no longer needed. Does that make sense? So if I have a primary curve and the curve is left leaning, so that it'll say they have a left primary curve. What direction do I want to do leaning towards? Away from it or towards it?
Away.
Towards it?
Towards. Yeah, because, yeah, it's directional bias. Exactly. If I have a curve, so if I have my curve, let me see, I used to have a spine here. Where is my spine? My spine is. Well, I can just, again. Come here. I've got a Cat 5 cable, that'll work. All right, so here's my spine. Right, spine should be straight. If I've got a curve going this way, if I keep leaning that way, it's going to make the curve what?
Greater.
Yeah, greater, right? So with the directional bias, we'd want to lean this way to try to force that curve to go to the opposite side. So typically with most questions, when they say the patient has a left or a right side curve, you're going to go towards that curve, as long as we're talking about the primary curve. And most of your questions are going to be on primary curves. So whether they're left leaning or left over a, what do you call those balls? Physio balls or Swiss balls. Or if we have to put a brace in, right? My brace is going to apply pressure to the right on that left side of the back, right? Because that's going to force me back to neutral. The idea is to get this curve and get the curve closer to here. That would be the ideal goal. And for most structural curves, if we correct the posture, it'll correct the problem, especially if we catch it early enough, right? Could a structural curve eventually become, or sorry, functional curve. Could a functional curve become structural?
Yeah.
Yeah, right. If you sit with that long term like this, eventually that right side of the spine is just going to break down from the pressure, right? And then now you've turned that functional curve into structural because you've got problems with the right side of the spine. Now, with the curve, let's start talking muscles now. Let me get out my color for muscles. We'll use blue for muscles. So I got my erector spinae on either side of the spine. The muscles on the side of the curve, so my left-sided erector spinae, are going to be lengthened or shortened.
Lengthen.
Lengthened, yes. Because they are going to go a larger distance. Does that make sense? Because now I've got this curve that I have to go around the curve for. Right? I wonder if flat earthers think that scoliosis is fake too. I don't know. Anyway. So if we lengthen, we strengthen. Exactly, Anthony. Right? And if it's short, we stretch. Yeah, that's the way I've always remembered. If it's lengthened, we strengthen. If it's short, we stretch. So on a lengthened curve, so if I have a left-sided curve, the left side of musculature is going to be lengthened. My right side is going to be short. I'm going to strengthen the left, stretch the right. And if I naturally have the patient lean to that left, I'm going to stretch out that right side anyway. Right? So that happens naturally. And honestly, the lengthen and strengthen, shorten, stretch applies to all muscles, really. Right? Even if we're talking biceps, triceps, if I got one that's contracted, I'm going to stretch it, and I got the other is going to strengthen it. It's kind of the way it works because we want to work on that reciprocal inhibition idea. And then as far as the curve itself goes, less than 25 degrees, we typically are going to do conservative treatment, which is therapy and bracing. 25 to 40 degrees, we're going to do a true spinal orthosis, which are the big the braces with the pressure points and stuff like that. And if it's greater than 40, we have to do surgery. There's nothing we can do for that. Right? So if it asks you, your patient has a scoliotic curve, what degree would require surgery? It's anything over 40. So it may say the patient has a 25-degree curve, 15-degree curve, 30-degree curve, 50-degree curve. That 50-degree curve would be the right answer that would require surgery. Because good luck getting, 50 degrees is pretty significant. Where are my gonies at? Everyone stole my gonies. Anyway, 50-degree curve is pretty significant, right? So let's see. There's 45. So there's 50. That's a pretty significant curve, right? Your spine's bent that bad, you got some problems going on, buddy. I'm just saying. Scoliosis, remember, scoliosis is right to left. Kyphosis is which way? Yeah, front to back. Kyphosis and lordosis are front to back, right? So just remember, if you have a question, don't confuse kyphosis, lordosis with scoliosis, right and left. And good news is scoliosis is only one term. We don't have like scoliosis and sclerotic or something for us. We have a right and a left different version. It's just scoliosis for both of them. Thank God. For once, they made something simple. Let's say the patient does have to have surgery. What are they going to do to the back? Kyphosis is a humpback, right? Kyphosis, the back is usually leaning more towards the back.
Scoliosis, they'll do a long fusion, right?
Yeah, they're going to do long fusion. Rods and pins. Yep. So Diana, remember so scoliosis is side to side, right? So right, left. And then if we go this way, here's the back side. So posterior, anterior. This would be a kyphosis. And then lordosis would be an anterior type curve. Does that make sense? Hunchback from Notre Dame, right?
Yeah, thank you.
Yep. Hey, Alex, what position did the Hunchback from Notre Dame play in football? Halfback. Yeah, he couldn't play fullback, unfortunately. Just kidding. Anthony's like, God. See, didn't you miss my jokes, Anthony? I'm telling you. The new students are getting all those wonderful physics jokes right now, and they're loving it. All right, so that's it for the basic musculoskeletal pathology. That doesn't mean you're not going to run into something weird, right? But those weird questions are going to be the 1%ers. They're not going to be yet 90 questions on, let me think of a weird musculoskeletal pathology. Leg calf Perths, right? You're not going to get a ton of questions on leg calf Perths disease. Or I don't even think of any weirder ones. There are all kinds of weird pathologies that happen with musculoskeletal, but you're not going to get a ton of questions on those. For the most part, those questions are going to be safety and energy conservation. Limping child's disease, yeah. I think we all had that, at least those of us that grew up in like the 80s, because it's usually involved after a spanking. We had the limping child disease. All right, neuropathology. This is probably the one that gets, well, now actually, for whatever reason, neuropatho is usually okay. It's usually cardiopatho that gets a lot of people for some reason. And musculoskeletal is usually okay. Neuropathology. We're going to go over a couple of them. And again, I just looked, I didn't add on Spina Bifida, but I'll cover it anyway for those of you that asked about it. So Alzheimer's, otherwise known by old people as old-timers disease. Is there really anything from a PT standpoint we can do? SKSCE, I don't even know what that is. So that's how weird that one must be, because I have no idea what SK. All right, now I'm curious because I don't even remember that. Hold on. I am not even. Oh, slip cap. Yeah, okay. That's just a, yeah, so I think Diane asked about this. Slip capital femoral epiphysis. That's literally just a form of hip dysplasia. That's all it really is. I mean, it's a specific form, but it's usually more about the, it's more about the growth plate than it is anything. But I'm going to be honest. Yeah, likelihood of getting a question on SCFE is pretty low. Yeah, those are the ones I would not worry about. I'd worry about knowing, like, you know, the important ones. Hip replacements, knee replacements. Alzheimer's, really not much we can do from a physical therapy standpoint. Right? There's no curative treatment for it. We don't necessarily know what causes it. There is a link to head trauma with it. Neurotransmitter deficiencies. There is some genetic inheritance to it, and there is some autoimmune links to it. But for us, safe, and you're going to see this common in almost every single one of these diseases: safety, energy conservation, compensation. Those are your main treatment protocols for almost all neurodiseases. So providing them with assisted devices, teaching them how to get in and out of bed and then conserve their energy, and then also making sure they don't fall, right? But for Alzheimer's, it's just a disease of the brain, right? And then also, what is another term, or what is a form of Alzheimer's we hear about a lot? Dementia. Yeah. So dementia is just a form of Alzheimer's, right? The main idea and the main difference between Alzheimer's and dementia is Alzheimer's typically is that forgetfulness, right? There are times where I really believe I'm starting to develop a long onset Alzheimer's. You're like, where's my soda at again? I don't even remember. Oh, it's right there. No, just kidding. But dementia is where they'll start seeing things and having psychological problems to go along with the Alzheimer's, right? Hearing voices. And usually when you get to the demented phase is where you start getting kind of mean. And that's not nice. You don't want to be mean. If I'm Alzheimer's or if I have dementia eventually, I just want to be that pleasant person that I don't remember anyone, and I'm always happy when you come in to see me. And I meet a new person every day. He's in the mirror. I appreciate it, Jason. You got it. Thank you.
You think that has anything to do with their reaction to the drugs?
I wouldn't
Some
doubt
people
it.
React differently to it.
Yeah, I wouldn't doubt there's some to that. Yeah. And there are some studies nowadays, Joe, that are also showing that if you have more frontal problems, so temporal to frontal region, you're more likely to get kind of the mean level of dementia. Which kind of makes sense, wouldn't it? Because if your frontal lobe's affected, you're probably likely to have, more impulse and mood control issues. 7-second memory, man, that's scary. I couldn't imagine that. And what were we talking about? Let's go ride bikes. No, just kidding. I have 7-second attention span problem. That's what I have. So with Alzheimer's, not much we can do about it. I will watch it. Thanks, Alex. ALS, the only thing we can do at that point is provide them with care. Early stages, we want to make them as functional as possible. Late stages, make them functional as possible. For the most part, we still don't know what causes it. There is a 10% link to inheritance, which scares anyone that has family member that has ALS. For ALS, a lot of the times you're going to be looking at how to conserve energy, how to provide them with safety, and then also, looking at questions where you're looking to see if you're providing them with palliative care, making their life safer towards death, or restorative care. And restorative care is not going to really matter. You're never going to make an ALS patient better. There are some burgeoning tests now, Riley, that are out there for ALS. We still don't have it fully nailed down because they still don't know the full gene code for it. But there are some out there that they're even starting to test for muscular dystrophy late stage and maybe seeing if that has something to do with ALS in the long term. For us, it's going to be supportive and preventative care. So early on, we're going to try to maximize function as much as possible. Late on, we're going to provide them with, pressure relieving cushions, wheelchairs, assisted devices, and respiratory care. Because ALS and actually most of the diseases that are out there, they're going to die of respiratory complications before they die of anything else. So you want to make sure that you're providing them with the necessary amount of respiratory care that they can get. Otherwise, that's going to be problematic for them. If they're early in the stage, we may work on gait. If they're late stage ALS, are we going to be doing gait training with them? Yeah, no, they're going to be wheelchair bound. So don't pick a gait question for those type patients. They're wheelchair bound. They ain't going nowhere. Well, here a second. I was looking up something. So yeah, so ALS for the most part, symptom control, treatment control, and family education as well. Bell's palsy. The one thing I want to stress on this one, because there's been a couple questions that I've heard of. I don't know. Now, again, we can't discuss what questions we get on the board, but I've heard rumors that there are some questions about E-stim with Bell's palsy. And what did I tell you about E-stim with Bell's palsy?
Don't do it.
Don't do it. Yeah. Now, we've always done it, right? I mean, literally, I can remember back sticking Russian pads on the patient's faces and make them make Joker faces with their muscles, right? But at this point, we know that there is some viral or systemic infection problem that goes along with the Bell's palsy. And if they have that, well, that's going to make it worse. Our big buddy is herpes. It loves to come out and hang out with us, right? Herpes simplex virus. So just be aware that's one of the, especially like cytomegalovirus or, oh my God, I just drew a complete blank on the one I want to talk about. The Herpes Zoster. There we go. It's almost like they knew it. They must have gave Justin Bieber Ramsey Hunt disease, Joe. I'm telling you, it was all PT final exams fault. Just kidding. Yeah, but why do we hear about some of these weird diseases? Because some random celebrity gets them. That's when we hear about them. I mean, that's just kind of the way. I mean, think about ALS. ALS really didn't get popular until Lou Gehrig actually had it. I just saw his Bieber fever. I'm ignoring it. So for Bell's palsy, intrinsic muscle strengthening of the face, right? Symptomatic treatment for pain. And we do know the faster they receive treatment, the faster the resolution of Bell's palsy. So if I'm having eye droop problems, I'm going to strengthen those muscles that kind of lift the eye up. If I'm having facial droop problems, muscles that lift it up and kind of make me smile. And with Bell's palsy, for the muscle strengthening, we just don't encourage the direction the face is going. So if you've got a Bell's palsy where the face is lifting up, kind of into that freakish, like Joker-like face, we want to go the other way. Does that make sense? So if I've got eye droop, I want to go eye elevation. If I got facial droop, I want to do facial elevation. If I've got facial elevation, I want to go facial drop. I will have to use that in my class. Absolutely. Your meme. I like it. I shall steal it. This meme is mine. And also with Bell's palsy, you know, ice can help quite a bit, mainly just because we know if it's a viral and we know that viruses don't like ice. But a lot of people don't want cold on their face. Think about it. That kind of sucks, right? Especially a cold pack. Or just imagine ice massage on like your buccal muscles. How much fun that would be. That'd be nice. You know, good news is you get to chill out. I'm so funny. Okay, I missed some diseases. Oh, they're pediatrics. Okay. CTS or just entrapment syndrome in general, because CTS is a form of entrapment syndrome. And entrapment syndrome, anytime you see it, just means the nerve is pinched. Right? Entrapment syndrome just means nerve is pinched somewhere. What causes it? Usually repetitive trauma. Could be RA, rare instances, OA. Pregnancy is big on entrapment syndrome. Sorry, ladies, when you get pregnant, unfortunately, your baby does bad things to your body. And diabetes mellitus 1 and 2 can cause entrapment syndrome. It doesn't matter what the entrapment syndrome is, whether it's ulnar nerve entrapment or ulnar nerve impingement, median nerve impingement, which is carpal tunnel syndrome. You have to identify where the entrapments occurred at, and then open that entrapment area up. That's kind of the treatment, right? So if I have carpal tunnel syndrome, this area is being closed off, so I have to open it up, right? The median nerve can become impinged. Well, it depends on usually go the opposite direction, right? So if my carpal tunnel is closed up like this, I want to stretch it out into extension. Does that make sense? And open it up. That's why a lot of stuff you're doing is stretching the wrist back, right? Joint mob stretches, anything to kind of open it up. Yeah, shoulder impingement, you want to open it up too. Absolutely, Alex. Right? If I've got a shoulder impingement here, as long as it's not in the AC joint, we don't really want to open that one up too much, right? But opening up that chest and relieving that impingement can be really good as well. So if I've got median nerve symptoms, my first three fingers, remember that, right? These are my fingers for median nerve. It can be impinged either here in the carpal tunnel, in the cubital fossa, or in the neck. Those are my three impingement areas for a median nerve. If the question asks about cubital impingement, well, that's what we're going to work on. If it works talking about wrist impingement, that's the most common carpal tunnel syndromes, right? What about ulnar nerve? Where are my three places of impingement for ulnar nerve impingement? Give me one of them.
Elbow,
Okay, at the elbow, which part of the elbow?
the cubital or the near the electron process.
Good. You said it, cubital fossa, right?
Cubital fossa, yeah. I was like, is it entire?
Cubital fossa, cubital tunnel, whichever you want to call it, right? It's not antecubital, right? Antecubital is the front. So back in that fossa back here, right? That's where we get the funny bone at, right? And he said it right, medial, exactly, right? Medial kind of posterior region. So we got that. We've got the neck it still can impinge at, right? All of our entrapment can impinge up here in the brachial plexus. And then what about at the wrist? What's the one at the wrist called where ulnar can get impinged? Ulnar nerve palsy is going to cause, yeah, but what's that? What's the space down here in the wrist where the ulnar nerve passes through?
The styloid?
Something Guillain or something like that.
Yes, Guillain, yeah. The canal of Guillain or Guillin's canal.
Guillain, all right.
Yeah, right? So all of that will cause ulnar nerve palsy. If I have median nerve palsy problem, I'll kind of get my fingers going like this. If I have ulnar palsy, I'll get fingers going like that, right? So canal of Guillain, back there in that cubital tunnel, and then up into the neck for the ulnar nerve. Radial nerve palsy. Never heard of the canal of Guillain? Oh, I'm going to tell Dr. Freskin that you said that.
I don't remember ever talking about that. Goodness.
G-Y-O-N. Guillain, or Guillain, I guess if you want to call it, right? One of my instructors once said, if you get a scammer that calls you from Guillain, you hang the phone up. The canal of Guillain. That was the way he remembered. I was trying to think what his phrase was about it. But yeah, canal of Guillin's the one of the areas. Radial nerve. Radial nerve is going to control which primary finger? All the extensors, good, right? And then also which finger primarily?
Thumb.
Thumb, yeah, it's going to go out to the thumb. Yeah, right. It goes out the extensors out here, but a lot of your thumb muscles out here are affected by radial nerve, right? Not kind of the feeling, but they're affected in a lot of those muscles in the thumb. So I can get impingement down here on the wrist, right? But that's kind of uncommon because the wrist itself on the extensor side has a lot of open space. It can get impinged up here where the brachioradialis is, or it can get impinged up here in the neck. Those are the main areas of radial nerve impingement. And again, like you said, the finger extensors and the wrist extensors are kind of my common wrist problem. So if I have a radial nerve palsy, I'll typically end up kind of limp-wristed or wrist drop.
And then isn't a fracture of the midshaft of the humerus pretty common to have a radial nerve?
Good, why?
Because of the way the radial nerve runs through.
Because it wraps around the shaft of the humerus.
Or around the humerus,
Yeah.
right?
Yeah, that nerve, like if you ever think of, and this is, again, I'm not attacking anyone's religion, but if you ever want to say that we had an intelligent designer, the radial nerve disproves that. Because why would that wrap around the humerus if we had an intelligent design, right? Let's not even go into the laryngeal nerves, but that's beside the point. But yeah, so it kind of goes up and it wraps around the humerus to get up into the brachial plexus. And that's, yes, midshaft humeral fractures will cause wrist drop. Yep. But the good news is a midshaft humeral fracture is kind of hard to get, right? The humerus is pretty strong, but if you end up with a wrist fracture or a humeral fracture, it's not feeling good. I'm just saying. It hurts slightly less than a femoral fracture. So all of those syndromes that we have will present with a very specific way, right? Again, median nerve, ulnar nerve, radial nerve, right? And then you're just going to treat them symptomatically. Does that make sense? And you're going to look at what the problem is, relieve the compression area, and then stretch them out. Have I lost anybody yet? Everyone's still okay? Not gone dead yet? I've been talking for like an hour and a half. Yes, that is a good image of the radial nerve. I was like, do I want to click on it? Then I saw it was a med health one. I'm like, okay, Joe's not porn bombing us here. We're okay.
So if you had an ulnar nerve entrapment, you would want to put them into elbow flexion. Is that right?
Well, elbow flexion, yes. And if it's trapped at the elbow, yes. Right? If it's trapped out the canal Guillain, radial deviation, right, to open it up. So it just depends on where you have to pay attention to where the entrapment is itself. Yeah, the only reason I'm getting hesitant, Joe, is because I just did a whole Discord call, not today, but last night. And for some reason, evidently, when you do those Discord calls, people like to come in and porn bomb you, and it's really annoying. So, like, what's this thingy picture? I'm getting gun shy about it.
Yeah, I just went into a Discord and like it was for financial stuff, and
yeah,
they were like, "What? Oh, this guy's got a white name. Who's this guy?" Because it's like I don't have any logo, or I'm like, "What is it? What are they talking about?"
Yep, it's bad. Discord is a great place, honest. But yes, so we relieve compression. We may splint them too, right, Riley? Maybe we might splint them into flexion or extension, depending upon what the problem is. So yeah. And then also the nerve glides. Do you remember those from way back in Therex 1? Those also can really help with that. All right, epilepsy, right? This is a disorder of seizures. And you just kind of have to remember the difference between them. So a petit mal is kind of the baby seizure, right? Usually petit mals don't lose consciousness. That's just kind of where they kind of seize slightly. A grand mal, or a very bad seizure, is one where they do usually lose consciousness, and then an absence where they're not there. The interesting thing, I think I mentioned this when we talked about TBIs, is there is a link between a single TBI and epilepsy. That is just scary, right? For us, the treatment is if the patient is having a seizure, we clear the area, lay them on their side, and open their mouth if we can. Now, if their mouth is tonic, don't try to pull their mouth open, right? Tonic meaning that's all tied up, right? Don't be like, open your mouth, open, come on. No, don't do that to them, right? You just don't move them. They're going to be on meds for it, right? Anti-seizure meds. And again, most of them could cause weight gain, fatigue, all that fun stuff to go along with it. And then for them, energy conservation is going to be the big one. And again, back to the meds for seizures, most patients that we're finding that like CBD is really good for these patients. I don't know what it is specifically about the specific part of CBD that affects seizures, but for whatever reason, it's really good for them. And it seems to have no necessary side effects. So, maybe we need to research that more. Dilantin, yep. Yes, so Dilantin is anti-seizure, baclofen is anti-spastic. And there's no really easy way to remember that, unfortunately, Diana. I wish there was, right? Unless you want to dial up the seizure, maybe. There you go. That doesn't sound good. I don't want to dial up a seizure. GBS, Guillain-Barre Syndrome. It is caused by infections. Now, There is no link between non-motile vaccinations and Guillain-Barre, but there is a slight link between live virus vaccinations. Does anyone know when the last time we had a live virus vaccination? Like mass live virus vaccinations.
Wasn't it polio?
No, actually polio was before. There's a more recent one than polio. But yeah, polio initially started off as a live virus. You're right. It was 1976, and it was a flu outbreak of the same strain that came from 1914, 1918. So that was the last live virus that we really got. I mean, there are some vaccinations out there, especially if you're like going to a third world country, where they may give you some live virus in order to keep you from getting like some weird disease, right? I think I'd rather have that than getting the weird disease. But that was the last time we had a major outbreak of Guillain-Barre from vaccinations. But could a non-motile vaccination like a flu virus or vaccination cause Guillain-Barre to kick up? Yes, but it's not the vaccination that causes it. The vaccination itself triggers the rest of the latent viruses that are hanging out in the body to kick up, and that causes the Guillain-Barre. So like, let's say that you go and get vaccinated for next year's flu, and suddenly you're struck with Guillain-Barre syndrome. There's a really likelihood that you probably had a herpes infection somewhere hiding out in you, that as soon as you got that flu vaccination, it kicked up the inflammatory system for the flu, and it started ignoring the herpes, and herpes said, hey, let's give this person Guillain-Barre. And yeah. Bacterial infections can cause it as well, and then idiopathic. Initially with Guillain-Barre syndrome, symptomatic treatment is going to be hospitalization, right, with cardiac monitoring, because we want to make sure that the heart doesn't get weak. And most patients with Guillain-Barre will return to their premorbid state, as long as there wasn't any long-term damage done to their body, right? So for us, the main thing we're going to be involved in Guillain-Barre is gait training. So we're going to work on getting them better at walking. Huntington's is a genetic link. There's to that, women more than men. And for Huntington's, the main thing that you need to remember about Huntington's, which you'll get questions on, is reducing their choreiform movement, right? So that's that athetosis, choreathetosis, and just chorea in general, where they get those moves that are kind of out there, and spasticity, right? So treating spastic problems and reducing those choreiform movements, getting them to do more functional activities. It's not only present as some basal or ganglier damage can cause chorea as well, Anthony, but it's most common in Huntington's, yes. So if you get a question about chorea, the answer is probably Huntington's. And just like most other neurological disorders, if they have some sort of a chorea going on, the more you reinforce it or call it out, the worse it's going to get. Right? So if you're like, stop doing that wavy motion with your arm, their brain hears that and says, okay, I'm going to do more of it. Right? So redirecting them to something else, changing the activity to stop the chorea is a good idea, right? So if we're doing like maybe overhead reaching activities, well, let's change it to something cross body and change it up. Yeah, physical guidance is the idea. Yes, right? Yep. And just redirection. It's like a kid. If you don't want a kid to do something, don't tell them to not do it, because all it's going to make them do is do it. Right? I always love the greatest thing that causes, young kids to have sex is parents and teachers telling them not to have sex. Right? It is. Like, if you ask a kid, why did you have sex? They're gonna be like, because my mom told me not to. Or they're curious. But same idea here. The more you reinforce something, the more likely it is. And with a lot of these, even Guillain-Barre, MS, MG, Parkinson's, spasticity comes along with them because it's a neuro disorder, and it's usually got something to do back there in the basal ganglia. For MS, it's plaques on the myelin, so problems with Schwann cells. Warmer areas tend to have it more frequently than colder areas. It is the great crippler of young adults currently. And as far as everything else goes, you want to avoid warm areas, right? You don't want them doing exercises in heat. Not discontinue treatment, exactly. Right, not discontinue treatment. So if a patient has MS, we're going to do the medical management to treat it. Patients that are both MS, Huntington's, MG, and maybe even some Parkinson's are going to be on some autoimmune suppressants. So we have to make sure that we protect them from getting diseases. And with MS, they're going to have tremors. What kind of tremors does MS have?
Voluntary tremors?
Voluntary, right? Or otherwise known as intention tremors.
Intention.
Yes. Yep. Either of those is they'll call them either. So get to know them both. Right? So voluntary tremors. So when I try to move, and that happens, right? So anytime they try to move, you get an intention tremor possibly, depending upon how bad your day's going. So with MS, avoid trigger events, don't overwork them, cooling vest, pool therapy, and then we're there to maximize their function. What is the worst form of MS? Do you remember what the worst form is? Okay, how about this? What's the most common form of MS?
Is relapse remitting the most common form?
Yes, that is the most common form. Good.
And that's the worst form?
No, that's the best.
Oh, okay.
Yeah, that's why I switched it. Relapsing remitting means you get better, you get worse, you get better, you get worse, you get better, and you always kind of return back to normal. Primary progressive is the worst, right? That means that you have MS and you just go like this, straight downhill, right? It just gets worse and doesn't ever get better. So relapsing remitting is about, I think it's like 85% of all MS. I think primary progressive is like 10. There is other types like secondary progressing and then relapsing remitting progressing, but don't worry about those. Just know if it says primary progressive, worst type. Relapsing remitting, yeah, thank you for typing that. I was typing it out, but you beat me to it, so I won't have to type now. But relapsing remitting is the most common, and that's kind of the least dangerous of the MSs because it gets better and it gets worse. It gets better and it gets worse. Myasthenia gravis is a disorder of acetylcholine. So there is an excess or too much acetylcholine and not enough dopamine to counter it. It is not a shortage of dopamine. Dopamine levels are normal, but you have too much acetylcholine, right? So dopamine can't counter it. They're going to have thymus issues. A lot of times it is related to other autoimmune disorders, specifically like SLE. They may get thymomas, where they get tumors on the thymus, right? For us, again, they're going to end up with spasticity. They're going to have gait issues. And they need to be treated from a doctor from the medical perspective, meaning getting the medications they need to reduce that acetylcholine. So they need to be on anti-ACH meds. And I have to laugh that we're only hearing about myasthenia gravis now because the commercials about the people with the big eyes. I mean, you've seen those commercials on TV. Do you have bulging eye disease due to myasthenia gravis? Well, use this medicine because we've got new medicine for it, right? And I just saw one last night on USA that is a new medicine just for myasthenia gravis. I'm like, you know, the problem with this is that it makes everyone think they have myasthenia gravis. Stop putting commercials on television. With myasthenia gravis, the only other thing they might ask you about on the boards is if the patient goes into a myasthenic, I think I spelled it right, crisis. So that's an E, by the way. Don't quote me on the spelling. I probably spelled it wrong. But a myasthenic crisis. I did spell it wrong. I forgot an H, I think. Something like that. I don't know. Anyway. A myasthenic crisis. What is being affected by the MG? Do you remember? What would be the worst thing What would be the worst muscles to stop?
Yeah, I was gonna say cardiopulmonary system. is-
Cardiopulmonary system. You got it. Yep. Those would be the worst muscles to weaken and stop. So myasthenic crisis is a medical emergency. It means that their lungs and their heart are starting to stop because of the disease. And it's usually, again, if you look at the medicine, the research on it, they think it's probably because the ACH has overworked the heart and the lungs. And they basically say, hey, I need to reboot. And it kind of starts shutting down. So they need to go in, and they usually are going to end up on ventilator assistance for a little while. Not everyone that has myasthenia gravis gets a myasthenic crisis. But if you get a question on myasthenic crisis, your goal is to get them where?
To the hospital?
To the hospital. You got it. That's it. That's all there is to a myasthenic crisis. Get them to the hospital. Call 911. Call a code, whatever it may be. Parkinson's has nothing to do with parking your car. I had somebody ask me that the other day. No, it's not having a problem parking your car. The good news is that was on Discord too, Joe. I was doing a talk on neurodisorders, and the person's like, isn't Parkinson's where you have problem parking your car, parallel parking your car? Yeah, you're Parkinson. That's right. Yeah, exactly. So Parkinson's, reduced dopamine. So because you have reduced dopamine, you have too much ACH. It is not a problem with ACH. It's just that dopamine's down, so ACH is up. Goal for them is to reduce tremors. What type of tremors does Parkinson's have?
Pill rolling?
Pill rolling, good. Resting tremors, good. Yes, pill rolling and resting tremors. Non-intention or passive tremors are the other terms for it. Right? So it just happens when they're doing nothing. And pill rolling is kind of the worst of them, right? Just imagine somebody has Parkinson's and MS. That would suck. They'd have all kinds of tremors all over the place, right? So with Parkinson's, reducing tremors, improving gait, stopping festination, which is that freezing, improving the poverty of movement, right? Or the akinesia, or the slow movement, the bradykinesia going on. Safety and energy conservation are big. Compensation when they need walkers. What is the gold standard treatment for Parkinson's?
L-DOPA.
Yep, L-DOPA, right? Levodopa, or Sinemet, which is L-DOPA with carbidopa. Now, we are starting to see more of this to treat Parkinson's. DBS. Deep brain stimulation, right? Where they go in and stimulate the substantia nigra in order to create more Parkinson's, right? But L-DOPA and Sinemet are kind of the most common. And if the patient is on either L-DOPA or Sinemet and they receive their medications in the morning, that means we should plan our treatments in the morning, right? Yes, you want to plan it when the patient is at their peak treatment. Polio. Good news about polio. We don't see it very often because, well, we've kind of eliminated that with vaccinations. Even better news, it's coming back. Yay. I was just reading an article from the AMA talking about some polios that might now be resistant to the actual vaccination. That's not scary.
Is it Pakistan? Is it Pakistan that doesn't have polio vaccine?
Well, they have it. They have it.
Oh, okay.
Yeah, so Pakistan, Afghanistan are endemic for it. Right? And why is that? Because the World Health Organization can't get in there and vaccinate. Because literally in some of those countries, there are bounties out for the World WHO vaccinators. Like you can actually make money from certain parts of the Taliban or from, what's the other group? ISIS. If you bring them the head of a WHO vaccinator. Like that's not terrifying at all, is it? Like, yay. And I can't blame the people that are doing it because they probably don't have enough money to feed their family. And they're like, well, hey, here's a quick way to make a couple $1,000. Right. But yes, polio is endemic there. And then sub-Saharan Africa is the other area it's endemic at. right? So below the African belt. But again, guess what we have there? Problems with medical misinformation, right? You know, in that area, they have, you know, also pretty bad with AIDS, and they think that like eating white rhino testicles can cure AIDS or something like that. It is what it is, right? Polio, what does it affect most? What limbs? You had the idea. I know you did, Riley. The legs, the lower extremities. Yeah. I know you had it. You were just worried about saying it, weren't you? Yeah, it's primarily the legs, right? This is the original skip gym day at the leg for the legs day. Because these people that have polio, their legs are super tiny, right? And for the most part, most of the patients that have had polio are now at the point where they've passed away, luckily. So likelihood of seeing somebody with polio is pretty low. But full recovery from polio, unlikely. There's no medical management at this point for it. Lower extremities are most affected. A lot of times they're going to be in bracing, right? So either total hip, ankle, knee orthosis, what are those? Orthoses, and just knee orthosis, ankle orthoses, whatever it is. What is the surgery that you'll see commonly with these patients? Sometimes they ask about this, where they fuse the ankle. FDR was one of them, absolutely, Alex. Does anyone remember the surgery where they fuse the ankle, what that's called? Anamnesis, you're close. You're close to spelling. So if you're fusing joints, that would be a joint arthrodesis. Good. And there are 3 joints in the ankle, so that would make it a
triarthrodesis?
Tri or triple arthrodesis. Yep. Yep, you got it. Good. So triple arthrodesis is the common one of the ankle. And oftentimes, if you get a question on triple arthrodesis, a lot of times it's going to be in relation to polio. Why would they want to fuse the ankle in somebody that's got polio?
So that they can walk better?
Yeah, walk and stability. That's it. Yeah, because the ankle's all flippy floppy, they're not going to be able to walk. Right? So it provides them with a stable surface to balance on. I've been going for like almost 2 hours now, haven't I? Okay. So let me see what I got coming up here. So I think I might, what I'm going to do is I think I might break this up because I think I can see everyone starting to fade. I can see people's brains fading. So let's cover Spina Bifida, which somebody requested really quick. And then what I'll do is I'll break the rest of this up and we'll cover the rest next Friday. Because next Friday, the main thing I had on the agenda was research. And that's actually a really small presentation. So I can just add the cardio and the neuro or the brain pathologies to that. So Spina Bifida. Spina Bifida is primarily, and I don't have this on the slides, unfortunately. Spina Bifida is mainly a disease of children, right? I can write today, honest, because I don't want to keep you guys more than 2 hours. Your brains are, I can see the brain is melting down, right? Spina Bifida is children, right? It is a disease of child's in utero, right? So it happens when they're babies. The neural tube is the problem. The neural tube eventually becomes what structure on the human body?
Spinal cord?
Spinal cord, yeah, right? The spine and the spinal cord. So there's a problem with neural tube closure. So neural tube closure is a fancy way of saying the hard parts of the spine form, right? That's really what it's a fancy way of saying. So that the spine itself forms its casing around it. And we need that in order to not have problems with the spine, right? That makes sense. So if I have Spina Bifida, right? So if I have Spina Bifida, there are a couple different forms of Spina Bifida, right? So I know one of you guys mentioned it, myelomeningocele, right? So we have spelled it wrong, the E's here, myelo. You know what? I'm going to type. Let me clear this out because my writing is getting worse today. So let's type this out. See, I told you. Children in utero And it's the neural tube closure. I mean, see, I spelled it wrong again. You spelled it right. Thank you. I appreciate it, Anthony. My brain is just, I think even my brain's now shut down. 2 G's or 1 G? It's 2 G's and 1 C.
One.
There, was it 1 G? I just want to have a couple of G's there. Shush. Right. So we have myelomeningocele. We have meningocele. And we have occulta. Right. And I think there's one cystica. Cystica is the other one. I'm going to put this one down here, though. So out of all of those, which is the worst?
Occulta?
You would think it would be, because occulta sounds the worst, right? But myelomeningocele is the worst. So we actually have these kind of organized from worst to best, right? And what the difference here is in what happens. So if I have an occulta, I have a small area that didn't close. Didn't close. There we go. Right? You get a non-fusion of the vertebrae, so where stuff didn't close off. But occulta means what? If I say I'm involved in the occult, I'm involved in the hidden secrets of the world. Right? Occult means hidden. That means you probably can't see the spina bifida. Does that make sense? So there's no outward viewing of it. Some people will say that's worse because you can't tell if the child has spina bifida, but in general, structurally wise, it's the best form to get because that means all the structures are still in the spinal cord. Does that make sense? It just means that you have part of the spinal cord that didn't close off. Is that problematic? Sure, it still is, right? But could we go in and do surgery to repair that? Yeah, Jason's not in there, right? We could go in and put like a pin and a rod in there to keep it kind of safe. Or steal bone from somewhere else if we needed to later in life. So a meningocele is going to involve what structure do you think?
Myelomeningocele.
They're going to involve, it's a bubble involving the meninges. I probably butchered meninges, but don't sue me. I'm not good at spelling. This is not a spelling test, okay? I don't care what you guys say. Stop looking at me, Diana. Stop judging me. No, just kidding. So it's a bubble involving the meninges. So remember, with all of these patients that typically have spina bifida, there's going to be a little kind of clear bubble on their back, right? Even the occulta has a small one, but it's kind of hidden. And that bubble is where the spinal cord didn't close. So if you have a meningocele, inside that bubble are going to be some of your meninges. Does that make sense? So the meninges are going to kind of come out into that bubble. So like if I draw it now, right, let me get my drawer here. So let's close out the text. There we go. So here's my spinal cord, right? Front and back. So this is anterior. Here's my posterior. With the meningocele, or with spina bifida in general, I have this hole that didn't close, right? And a lot of times you end up with this kind of weird bubble thing. And the bubble can vary in size depending upon how many levels didn't close. Inside that bubble is just going to be some fluid. If it's an occulta, it's just got a little bit of fluid in it. And do they pop it? Probably not. But they may do surgery to close this off. If I've got a meningocele, now here's my spinal cord. The pink is the spinal cord. And then around the spinal cord in yellow are my meninges, right? The meninges are providing safety, right? What are the 3 layers again?
Subarachnoid, arachnoid, and the dura mater.
And then the last one.
Pia.
The pia mater. Good. Yeah. Right. So we have pia, subarachnoid space, arachnoid, dura mater going out. Right. So in a meningocele, the meninges kind of bubble out into that hole. Does that make sense? So the meninges, a meningocele means there's affected. Now, is that bad? Sure, because the meninges are also contiguous with the brain. So that means if they get a little bit of lengthening, that means it's going to pull on the meninges of the brain, and that can help brain development, hurt brain development, right? So a lot of those patients may have a smaller than normal brain size, which then is going to give them in the psychology world, what we like to call organic involvement, which is a nice way of saying they've got some mental retardation, right? Because we don't like to use that word. And I'll probably, when I post this on YouTube, get flagged for using that R word, I'm sure. But I'm using the scientific term, YouTube, not in the bad word. I'm not calling Jason anything. Right? So when meningocele, the meninges come out. In the myelomeningocele, what happens? Do you guys remember? Because that's the worst. In that, the spinal cord and the meninges come out through that hole. Right? So the myelo, right? Meningocele, the white matter and the meninges are now in the hole. That's the way I always remembered it, because I just think myelo meaning myelin, that means part of the spinal cord's coming out through it, right? Meninges, seal, bubble. Will that cause problems with gait? Could, right? Especially depending on the level of effect, right? Because let's say I have one level. If it's only one level of the spine, probably not as bad. But what if it's T12 or T5 to T12? That's my meningocele. That's problematic, right? The one girl that I treated, she was T1 to T4 was her meningocele, right? Yeah, a lot of problems. Yep. So we may have some retroversion, antiversion, depending on what happens, right? We're going to talk about that in a second. What about upper extremities? Our upper extremity is going to be affected. Not unless the meningocele is where?
Cervical.
Cervical. And it's pretty rare. Usually the meningocele honestly forms in the thoracic cavity. Okay, so it's pretty rare that you get a meningocele up in the cervical spine. I mean, it happens, but it's kind of one of those rare cases. Does that make sense? So impairments, obviously, with this, disorders of the brain, because all of that's pulling on the brain, right? We already mentioned talipes equinovarus, right? So clubfoot. A lot of times they're going to have early onset osteoporosis because they're not up and walking, right? Because they have lower extremity involvement. Sure, I can do that, Joe. No problem. Depending upon what muscles get involved because of the level of spinal cord will depend upon what's affected in the lower extremities, right? Because what if my myelomeningocele is at L4? Well, I might have fully functioning legs for the most part, except for the stuff below L4. It's kind of like a spinal cord injury, right? We determine the level of spinal cord injury based upon what happens. So it's going to depend upon what really happens. I think Joe mentioned it earlier. Almost all of these patients that have spina bifida have a very, very bad latex allergy. And if you ask me why that happens, I can't answer it because that's my answer. I've never researched why they have a bad latex allergy, but they have a really bad latex allergy. They may end up with scoliosis. They may end up with tethered cord syndrome. So all of that could cause problems. And the main idea with these patients, again, is gait. So they're going to have gait problems, learning disability. Is the child going to grow to full height, do you think?
No.
No, they're all going to be kind of smaller. Even if they have an occulta, a lot of times they're still going to have height deficits. So those of you that are short can use that as an example. I just had a spina bifida occulta when I was younger. No, right? So all of that kind of comes into play when we're talking about this. Now, the spina bifida cysta, or cystica, because I forgot about that one. What do you think happens when you have spina bifida cystica?
You have a cyst on your spine?
Yeah, you have a cyst that grows in that area that didn't close. Right? Now, cyst, is that a normal growth or an abnormal growth?
Abnormal.
Abnormal, right? You can almost think of a cystica as a form of cancer almost, right? It's a cyst. It's not cancer though. It's not a cancer of the spine. But so in the case of when we have that kind of like curvy hole, now a cyst forms in there. That might be the time where they have to go in and cut that out. Does that make sense? But then we run into problems because what if they have a myelomeningocele cystica, where they have that whole spinal cord going in there? Now, you're not going to have to know about that for your boards, please. I see Riley starting to freak out right now. Right? That's fine, Diana. You can watch the recording. Thank you. If they have that myelomeningocele cystica, now we've got that spinal cord and everything going there, plus the cyst. And if they have to go in and remove the cyst, we're going to be problems.
So would they just like do a resection?
They could. Yeah. It just depends upon what happens with that child and what our all-time goals for that child would be, right? I've seen kids when they've had really, really bad myelomeningocele that their legs just come out and they look like little flippers. They don't grow right. At that point, it's almost better to do what to those legs? It's almost better to amputate them, right? If they come out like little frog flippers and they're not normal legs, they're never going to stand on them, right? It's almost better at that point to get rid of them and teach them how to live without the legs than it is to have them. Does that make sense? And so they might go in and then seal that myelomeningocele off and just say, we're just going to amputate the legs and they're never going to grow anyway. So it just depends upon what they're doing. Does that make sense did that help for those with myelomeningocele and with spina bifida? I think it was Anthony that asked about it, I think. Okay, cool. I'm going to close out of my screen here, and then I'm just going to bring my big old face up. Yeah, hard question on the feet about it. Yep. And again, like I said, I still have cardiopathology and some brain pathology to go over. That's fine, Alex. Just watch the recording then. The last thing that I'll cover this because Joe had asked about it, the difference between aphasias, right? So with our aphasias, there are three main types of aphasias. What are the three main types?
Broca's, Wernicke's, and global.
Yes, Broca's, Wernicke's, and global. Good. So if you have Broca's aphasia, what's the other term for Broca's aphasia?
Broken speech.
Broken speech. So that means I'm having trouble expressing myself. So expressive aphasia, right? So I'm going to have stutter-like motions. I'm going to have very kind of haltering speech, right? Versus Wernicke's, which is fluent aphasia or receptive aphasia as well, meaning they may not understand what you're even saying to them, because Wernicke's has a little bit to do with translation of speech as well. So depending upon how bad Wernicke's aphasia is, they may be saying normal words, but they aren't what they want to say, right? These are the patients that can say some weird things to you, like, so how are you doing today? Dog flies backwards outside house, right? And what they really meant to say was, oh, I'm doing fine. How are you?
I'm sorry, Mr. McKeever, you said Wernicke's aphasia is receptive speech and what else?
And fluent. Yeah, so they have a problem with getting those kind of words out. Yeah, Wernicke's is weird speech. You're exactly right there, Anthony. That's a good way. Broca's broken speech, Wernicke's weird speech. But also remember, like I said, that Wernicke's can also be receptive, meaning they have problems understanding what you're saying. So to them, your speech might be weird. Does that make sense? So you're saying something and they hear dog fly backwards outside house. And they're like, why are you talking about dogs? Right? Both of them may end up using something to write with, because for whatever reason, even though they have receptive or broken kind of fluent aphasia, any problem with that, writing sometimes isn't affected, right? They're sometimes able to write out at least what they want. Global aphasia now knocks out everything, right? Global aphasia is a combination of Wernicke's with Broca's, and often also then affects their expressive aphasia when they're writing. That's kind of the worst case scenario for patients. right? Because they may not understand what you're saying. They can't get anything out. And even if they try to write it out, they're having problems. Oftentimes, if they have global aphasia, they're eventually going to choose to become functionally mute, right? Because if what I'm saying is not making sense to anyone, why do I need to say anything? It's safer for them to just say, forget it, I'm done. Does that make sense? Does that help clear up that for Joe? Or Joe, was there something else you had a question on about them?
I never knew in school that it was only, those areas are only on the left side of the brain. So are they going to be is that correct or no?
Yes and no. They are primarily processed on the left side. How's that?
Okay.
And the reason I say that is the left side is the active side. There are some signs that show that we actually do have a right side Wernicke's and Broca's area. They're just not active. That's part of that. That's part of that whole neuroplasticity part, if that makes sense.
Is there certain CVAs that are going to be more likely to be?
Yes. Yes. So typically if it's temporal or below, so temporal parietal, strokes are going to be the problematic with Wernicke's and Broca's, and specifically left-sided those areas. Does that make sense? So your middle cerebral artery is going to affect that. Posterior cerebral artery, not typically anterior, usually anterior leaves speech alone. And then anterior, one of the inferiors, but I don't doubt you're going to get a question on one of the inferiors also affects it. I just can't think of it off the top of my head right now. But also damage to that lobe. So damage to the left side of the head from trauma could cause aphasias. Like a TBI that's really bad, especially if you've got especially when they've got a temporal parietal trauma, that can really cause problems there. Say maybe you got in a car accident and you smashed the side of your head off a window. That can cause some speech problems. But yeah, I don't like to say that there is no Broca's or no Wernicke's area on the right side of the brain, because there are some research that shows there may be. But for most of the effective research, yeah, Joe, most of it's left-sided effect.
Cool. Appreciate it.
Yep. Does that make sense? Does that help out? We good on those? Everyone else fried? Yeah. Okay. So let's stop the recording here. And what we'll do is we'll finish up with the rest of the pathology on next Friday and then cover the research. Again, research, I'm going to try to hit you with a 1,000-foot view. I also want to correct spin and snout, because I just want to correct that again before you go to your boards. Okay. So we'll cover that next Friday as well. So I'm going to stop the recording here.